I'm pleased to announce that our moderator for today's event is Dr. Arif Awan. Dr. Awan completed his bachelor degree in biochemistry and medical degree in the year 2013 from McGill's University, while working on projects in cancer cell signaling and bioinformatics. He completed his residency in internal medicine and medical oncology in 2018 from McGill's University. He completed a breast cancer fellowship at the University of Ottawa under the guidance of Dr. Mark Clemens and John Hilton. He is currently a medical oncologist and an assistant professor at the University of Ottawa, where he leads the Tumor Agnostic Clinical Trials Group, Breast Cancer Clinical Trials, and Precision Oncology Initiatives. Please join me in welcoming Dr. Arif Awan to today's event, and I would like him to proceed with his overview of our selected topic.
Thanks a lot, everybody, for joining this afternoon. So I'll talk very briefly about the translational life cycle and sort of where we are at with some therapeutics and clinical treatment of patients with breast cancer. And then we have fantastic speakers and Dr. Ramahi and Dr. Savard. So these are my disclosures. And then I would want to start always with hope. So I think if you look at the last couple of decades and we consider treatment of patients with metastatic breast cancer, so at the turn of year 2000, patients with metastatic breast cancer, if they were hormone receptor positive, so that's about 70 to 80% of our patients, their life expectancy was 2 to 3 years. And with the latest clinical trials, it's a little over 6 years. Patients with a driver in HER2 had a life expectancy of about 1.5 years, but now the life expectancy is 6 years. But then we see other cancers, triple negative being hormone receptor negative and HER2 negative. There hasn't been much improvement for this patient population. So their survival at the turn of the millennia was 1.5 years, and it's in the latest clinical trials, it's about 2 years. So improvements in some, but not so much improvement in others. So there's lots of work that still needs to be done. But globally, if you look at the burden of breast cancer in 2022, there were about 2.3 million women who were diagnosed with breast cancer, and 670 of them passed away from breast cancer. So I find this is a bit of a dated slide, but it summarizes the translational life cycle of breast cancer, and perhaps it can be expanded to other oncological fields as well, where initially any research starts with a question, and the question is generated from primary evidence, which can be from clinical data looking at patients' genetic mutations, expression, circulating tumor DNA, or circulating tumor cells, biomarkers, or experimental data in form of cell cultures, animal models. And once you have a hypothesis from there, then nowadays you've got multiple additional omics that we can use, and not just bioinformatics. So a lot of that information can generate additional hypotheses in conjunction with pathway mapping, targeted treatments, patient stratification, patient prognostication tools, and being able to monitor responses. So when you use all of that information and translate it, eventually with the goal being that you want to give the right patient the right treatment at the right time. And that is the premise of personalized therapeutics. So we maximize response of patients and minimize toxicity, but eventually all our patients, unfortunately, especially in the metastatic setting, would develop metastatic treatment resistance. So figuring out why patients fail treatments, develop drug resistance, and reiterating the entire process of making it another life cycle. So I've identified from this reference and others, the major areas where work is being done and required, I think, in patients with breast cancer. So it's really for genetic and epigenetic changes that cause cancer, and also in normal breast, determining effective and sustainable lifestyle changes, chemo prevention for breast cancer, tailored screening, molecular drivers for breast cancer, understanding mechanisms of tumor heterogeneity, markers of treatment sensitivity, whether that's radiation, chemotherapy, immunotherapy, endocrine therapy, and others, determining optimal treatment for patients using multimodality imaging, improving survivorship, and having clinically annotated samples that can be used to generate additional hypotheses and work. And I think nowadays, our technologies have improved substantially, so we can molecularly characterize these diseases and also use artificial intelligence to manage the vast data that's created while focusing on equity and diversity. So the problem I mentioned is every patient that we see in clinic with metastatic disease eventually will develop resistance to their disease. And when it comes to breast cancer, the most common variety being hormone receptor positive, This could be endocrine resistant, or it could be endocrine independent or endocrine dependent. So endocrine dependent pathways rely on the estrogen receptor, where there's mutation in the estrogen receptor being developed, and endocrine independent rely on many different canonical pathways for signaling that we see, like PIK3CA, AKT, cell cycle, MAPK, and multiple growth factors. And we can see there's lots of drugs in development, particularly when it comes to ER-dependent and ER-independent cancers, where, for example, all of these different drugs are in development in different phases, targeting different mechanisms of resistance that is ER-dependent. And when we go to ER-independent resistance, we talked about the pathways being involved, and we can see, again, many agents are being developed to overcome ER-independent resistance for these patients. So hopefully they can live longer with lesser toxicity, and combinations are being explored. When it comes to HER2-positive breast cancer, where there's a clear driver for breast cancer, and we've seen great improvements over the last couple of decades, we see that this is a non-ligand growth factor, but you've got, again, the canonical pathways being involved. And now the HER2 expression is becoming increasingly important with more potent drugs, where even HER2-0 or HER2-1 plus patients with very little expression of this target could have response on new, very potent drugs. And we see that a lot of these drugs are in development and showing some good results. Then the orphan disease, triple-negative breast cancer, where we have not seen so much improvement over the last few years. And we see that because it's by definition the most heterogeneous group, and we characterize it, and there are many different targets being explored. And one of the newest modality of treatments we have are antibody-drug conjugates, where you've got an antibody for a surface protein attached to a linker, which is eventually attached to a chemotherapy. The idea being you want to deliver more chemotherapy where it's needed in the cancer type. And we see that there are about over 300 of these in development for different cancer types, and over 10 of them specifically for breast cancer. And these are some of the targets that are there for breast cancer. So with that, I want to sort of highlight the patient's cancer journey. When I characterize that in detecting cancer before they develop, so this could be identifying patients who are high risk of having the genetic syndrome or developing novel screening tests. And Dr. Ramahi today will be speaking about one such technology. And then making the most exact diagnosis for patients using molecular testing and starting the best treatment at the right time. And we can only learn that by doing clinical trials. So whether it's a targeted therapy, immunotherapy, combinations, determining resistance. And Dr. Marie-France Savard will be talking to us about a clinical trial program, and then eventually identifying patients who would develop resistance, sometimes even before they have clinical symptoms. So with that, I would like to introduce our speakers today. So it's my pleasure to introduce Dr. Omar Ramahi. Dr. Ramahi was born in Jerusalem, Palestine, and he received his bachelor's in science degrees in mathematics and electrical and computer engineering from Oregon State University in USA. And then he went on to receive a master's and PhD degree in the same fields, but electrical and computer engineering from University of Illinois. He is presently at Waterloo. He's a professor with the Department of Electrical and Computer Engineering at Waterloo. He has authored and co-authored over 500 journal and conference technical articles on topics related to electromagnetic phenomena and computational techniques, including co-authoring books. He's received several awards, including most recently in 2022, he's recipient of the University of Waterloo Engineering Research Excellence Award. So he'll be talking to us about a topic that I'm quite interested in hearing about, which is challenging in breast cancer detection and using technologies, particularly looking at radio waves, if they can help us fill this important gap, which is relevant to many patients. And then it's my colleague, Dr. Marie-France Savard, who is a clinical investigator at the Ottawa Hospital Research Institute. She's also a staff medical oncologist and an assistant professor of medicine at the University of Ottawa. She serves as a co-lead of the REACT program, which is a pragmatic clinical trial program she'll be sharing with us today, and also co-leads the cardio-oncology program at the Ottawa Hospital. Her real focus is on optimizing breast cancer care using pragmatic clinical trials, and she's one of the strongest advocates for patients that I know of. So with that, I will hand it over to Dr. Ramahi and then Dr. Savard. Thank you so much.
Okay, thank you so much. I appreciate the invitation so much. So I am talking about a new modality for breast cancer detection. It's a bit unconventional, so you have to bear with me. It is not an incremental work, okay? It is not something that is trying to push the technology that is available nowadays a bit further, okay? So It's very exciting, and I'm really, really thrilled to share this with you. So it's about the detection. All right. So the title that I chose is a little bit intriguing. Can radio waves fill the gap in the breast cancer detection technologies? Some of my presentation will be very broad. Some of it will be very little, will be very technical. So bear with me. It's for the technical savvy people who are listening. And we will conclude with some very interesting findings. All right. So let me see here. All right. So I'm not going to give a background. Everybody here probably who is watching this presentation or this program or this seminar is familiar with the problem of detection. We want to detect breast cancer during its early stage. That's the key. And the statistics overwhelmingly show that if women catch cancer at an early stage, then they have a high rate of defeating cancer. So I don't think anybody will disagree with that, and that's why we've been heading in that direction. Now, I want to sensitize you. I want to keep track of time here. I have 50 minutes. So I want to sensitize you to the different words that we use when we try to look for cancer. There's screening, there's detection, and there's imaging. And each one implies something different. What we're doing in this work is trying to detect through a new word that I've coined, impressioning. Let's see what we mean by that. So let me just start by blowing my horns, so to speak, to say that most advances in screening and detection came from electrical engineering field, which is whether it's MRI or mammography or ultrasound or CT. Okay, and these are the four most prominent methods that clinicians use to detect or to look for cancer. So what is our vision? I always start with a joke. Let's pick someone who is extremely rich, like Oprah Winfrey. If Oprah Winfrey wants to have the best technology, she will not have access to it on a daily basis or a monthly basis or a yearly basis, perhaps. Why? Because CT is dangerous. I will talk about that. Mammography is not very effective. Ultrasound is not very effective. And I'll talk about the specific, what I mean by effectiveness soon. So the vision is to deliver a cheaper, more sensitive device. And we want it to be sufficiently inexpensive such that it will be available in low-cost clinics. Because it's a fact that women with less income are the ones who really suffer the most. This is a fact. And also, breast cancer is no longer a disease of so-called developed countries. It's right now mushrooming at a large rate in countries even like Yemen, which never heard of breast cancer. Of course, there are reasons behind that. That's not the subject of our talk today. So can we use low-frequency electromagnetics? Very interesting thought. Let's see. Let's go over the methods, some of the three available methods. You know, we see these numbers. I'm not going to go into the details, but we see these specificity figures and the sensitivity figures for mammography, for ultrasound, and for MRI. And they do vary. But there's something hidden here, is that these specificity and sensitivity metrics are a lump sum, an average number. Okay, so, and for example, a woman with dense breasts will have very, very low sensitivity and specificity than what you see here. Okay, this is a fact. Okay, women with the low density, less fibroglandular content in their breast, these numbers might be even on the conservative side for them. They might have a better figures for those people, for those women in particular. All right. So if we look at MRI, well, MRI is really an ancient technique. I mean, it's more than 45 years old. Can we do better? The question is. What about X-ray? X-ray is a very old technique. I call it a prehistoric technique. And X-ray, which translated to right now what we call mammography. Well, mammography is an all-encompassing, but let's specify it. Mammography based on X-ray is really an old technique, and it has a lot of issues with it. Most prominently is that it's not very effective for dense breasts. And also this cartoon that you see in front of you, I talk to many women and they tell me it's a very, very painful exercise when they do the compression. And this compression doesn't work for a good number of women who have large breasts. Okay, so why not use microwaves, okay, or radio frequency? The advantage of radio frequency, it can penetrate flesh, bones, and muscles easily, okay? In fact, the penetration sometimes even go beyond the chest itself, go to the content of the chest, the heart, the bones, and so forth. It's the same technology and frequency as cell phones. So the what we call the plumbing aspects of it, the circuitry is not expensive. Okay. So that's the appeal of low frequency electromagnetic energy. Now, what are the other advantage of it? It's non-ionizing. That's a big plus. The system that I will show you that we're developing gives energy lower than what the cell phone does. So in other words, a woman with a cell phone next to her breast has more radiation coming from this cell phone than from the system that we're proposing. Very inexpensive in comparison to practically everything that you can think of. And we're not talking less expensive by 10% or 20% or 30%. We're talking by more than one order of magnitude less expensive. And also it uses it takes advantage of mature technology that had been the realm of radar defense and the defense establishment. Okay, now, am I the first one to think about using low frequency or microwave for breast cancer detection? Not at all. There had been many methods proposed, and I'm flashing some of them in front of you. The idea was based on radar technology or inverse scattering technology. Please focus on this point that I want to mention. Those earlier methods, okay, were based on the fact that the composition, the tissues that compose the breast have different dielectric permittivity numbers. That was the key. This became a big thing in the early 90s. There's historic reasons why people started looking at this in the early 90s. We can talk about it later. There's always a reason why certain things happen at a certain time. Okay, but these methods, I'm not going to go over the details. Here's another photos that I picked from several papers. Dartmouth had been pioneering a method. University of Calgary has been pioneering a method. McGill, University of Bristol. And these methods are very, very sophisticated. But I want to be frank with you. These methods are not clinically available right now. So there's a lot of publications on these methods, but you cannot go to any clinic around the world, as far as I know, and get tested with these microwave-based methods. The reason is that they're based on what is called in the field of mathematics and electrical engineering, they're based on inverse scattering. Inverse scattering is a very complex method. The background of the inverse scattering is that it's good for radars. It's good for things that are, you know very well what's inside of them, okay? So that's why when it comes to the human body, the thinking has to be different. We really have to think different. When it comes to biomedical engineering for detection of anomalies within the body, the thinking has to be different. The method has to be simple to start with, okay? So here's another examples of systems. For instance, if you look at this one, it's quite complex. Why? Because it's based on determining the composition of the breast. Look at that point. It's based on determining the composition of the breast. Now, when you do MRI or CT or mammography using X-ray, you don't go to the doctor doesn't tell you, I need to know what's inside of you to start with. Okay. The doctor doesn't tell you, I need to know the permittivity or the dielectric constant of the fibroglandular tissues that you have, or the dielectric permittivity of different types of cancers. They don't, okay? They just put the woman, they do the test, and they try to interpret the data. So this is the fact. After almost 30 years, we don't have a commercially viable method based on these techniques, okay? Now, what do we propose? We proposed is that, first of all, one of the assumptions that we have, and it's not, I mean, we work around that assumption as well, is that the left and the right breasts of a woman are morphologically and physiologically identical. Of course, there's symmetry, right? There's symmetry. So when I say they're not identical, in the sense that my hands are identical in one perspective, but they're not, because they're not a copy of each other. They're a mirror of each other. Okay. All right. So now the fundamental physiological principle that we work with is that if one breast has a tumor, it will have a different microwave signature. That's the key. It has a different signature. All right. So how did we evolve to this point? Well, we looked at phantoms in the past, and in the past, we would make these phantoms in our lab. Okay, so I started with this one. This is something that we could make in our lab using a lot of chemicals, very messy chemicals. The shelf life of these early phantoms was limited, so they degenerate after a while. This technology that you see here resembles a realistic breast. Was developed 5 or 6 years ago. It's a very expensive phantom. It was about $3,000. We got 2 of them. And you can actually request a tumor to be placed in that phantom. But this technology is old. And right now we have moved to a point where before I show you the first slide, the next slide, is that we have databases of MRI-generated numerical breasts. These are extremely accurate. Why? Because they were generated from MRI scans, MRI slices. From those slices, we can form a numerical model for the breast, with or without the cancer. Number 2, we have these 4 classifications, C1, C2, C3, C4, and they're based on the content, based on the fibroglandular content of the breast. Now, how does X-ray work? So we were inspired by how X-ray mammography works. X-ray, you put a beam of X-ray on top, and you have a film at the bottom of the breast. You have a burst, and then you take an image. It's a very simple method. Mammography is very simple. Now you do the compression to increase the transparency of the X-ray through the breast. Of course, what you see in front of you, this system can be rotated, but not fully, by the way. This is a bit deceptive when they say they can be rotated, because the cleavage of the woman, you cannot put a screen in the cleavage, you see? So there is a caveat there. So, but even if it works, of course, it is dangerous. So this is the punchline. Can we make a film, but using an electronic circuit? Okay, so I show it right here. You see here, we have a film at the bottom, okay, and we have an X-ray burst on the top. Now, what do we get in X-ray? We don't get an image, right? We get an impression. There's a big difference between them. It's not that I'm trying to parse words here, but there's a big difference. MRI gives you a slice, an image. CT gives you an image. Mammography gives you an impression. Big difference. Okay, but it's not to minimize the importance of the impression. So what we're trying to do is to mimic X-ray, but using an electromagnetic wave. So this slide summarizes it all. You have an incident wave from the right coming, interrogating the breast, and then you have a film. This film is not an X-ray film, but it's an electronic board. Okay. So it's a fundamentally different physics. Okay. What I like to say here, you see on the left-hand side, why does X-ray work to a certain degree? Because X-ray goes in straight lines. It's a ray-like radiation. Okay. So it either it gets reflected or absorbed or just goes through. That's why you get an impression. If one were to think of low frequency electromagnetics, they say, wait a minute, this is nonsense. Electromagnetic waves go in a straight path. That is everybody realized that that is the case if the frequency is extremely high. But if the frequency is extremely high, we don't have any penetration through the breast. You know, the skin absorbs most of the electromagnetic energy that falls on it. So we have to go further low in frequency. I'll skip some of the details. These are some technical details, but the finding, this is a physics-based finding that we discovered, not invented. You cannot invent physics, but we discovered this phenomena is that if you have very low frequency, this is a surprise, the energy transmits or propagates in a ray-like manner. Sounds counterintuitive. We proved it in our publications. Okay, I'll skip this. So now, because of time, I'll skip some of the details, but how can we capture the impression? Well, we did a lot of work in energy harvesting. It's a very fascinating story. I don't have the time to narrate this story because one thing leads to the other. But when we have in energy harvesting, we designed this surface that you see right here. Very simple, very cheap, okay? This surface absorbs all the energy that falls on it, okay? Well, this is the key. We took this surface and we said, can we use it to obtain the impression from the electromagnetic energy that falls on the breast? So you see this surface is where the classical X-ray film goes, okay? And I'll show you, and this is the back plumbing, if I may say, the back of the circuitry. So you want to absorb all the energy. This is another demonstration of a different surface, the front, the back. The back, each of these little black things that you see, they're resistors that capture the image. You know, in X-ray, you have basically an image captured by the film, basically very, very tiny pixels. You can think of them as pixels. Here, we're doing the same thing. All right. So, and this is really a schematic of our system. You have an antenna here. I show a horn antenna. It doesn't have to be a horn. We improved over this technology. We have a signal generator, and we have our metasurface. Metasurface is basically the film, the electronic film that captures the impression. We process that, we obtain that, visualize it, process it, and make the interpretation. I'll skip these details. These details, because there's fine details here, I don't have the time to go over them, but this is how we design the metasurface. It's very cheap, but it requires a lot of thought to design it. Okay, the key here is that this is the first time we designed this was working at about 1.8 gigahertz. The latest design that we just published a few months ago works at 200 megahertz, 200 megahertz. So 200 megahertz, the energy penetrates the entire breast, whether it's C1, C2, C3, C4, whether the fibroglandular content is high or low. Okay, and we get these interesting impressions. Now, these impressions, of course, AI can be added to improve the interpretation of these impressions, but the impressions clearly show difference between a healthy breast and a breast with a tumor. Now, we cannot claim too much. What we're claiming is that we can detect a tumor. Now, is this tumor benign or not? That's something at this point we're not in a position to determine. So basically, it's the first line of screening. The woman has a problem, the doctor will refer her to further screening. If there's no problem, everyone is happy. So this is the latest technology that we developed. Actually, we managed to improve the system by working to 200 megahertz. All right, so The implications are really, really huge. Okay, women will not hesitate to screen monthly. Okay. And I want to remind you how blood pressure used to be gauged. We used to go to the doctor once in a blue moon, but right now most of us test their blood pressure at home. So women will not hesitate to screen monthly. There's no danger. Of course, it's not ionizing, it's not painful, none of that. Very inexpensive system. It results in early detection, leading to improved health. And financially, it also has significant impact. All right, I think I have my 15 minutes consumed with probably a minute and a half extra. So I sit here to be continued because we have a lot of excitement, lots of exciting developments that we came up with in the last 3 months. This has led to the formation of a new startup in Ontario, ESI Imaging Incorporated.
Okay, good afternoon. First, I would like to thank Dr. Awan and the OICR for the opportunity to present on the behalf of the REACT investigators on the Rethinking Clinical Trials program, optimizing care of patients with breast cancer through pragmatic clinical trials. So here are my disclosures. The REACT program was funded by Dr. Mark Clemens in partnership with the Ottawa Hospital Research Institute in 2014. It is a unique research program that aims at improving the lives of people with cancer through patient-centered pragmatic clinical trials. The REACT program has generated interest among clinicians because it answers unmet needs and gaps in the daily practice. First, in general, the research system is mainly focused on funding trials of new treatments and not comparisons of effective established interventions. As you know, in oncology, multiple trials comparing new drugs to the standard treatment run at the same time. This leads to multiple reasonable choices for a same indication. The problem is that clinicians are often left without ever knowing which of the new drugs is the best, as head-to-head comparisons are not always done by pharma. This results in variable, expensive, and inconsistent care. Furthermore, there is little interest in funding comparisons of simple, practical interventions that affect everyday care. The REACT program seeks to address this. Second, the anti-cancer drugs are developed and approved at maximal doses and schedules, and new drugs are evaluated in populations with few comorbidities that don't reflect the patients we are seeing in clinic. Because of this, healthcare providers soon start reducing doses and frequencies, often outside clinical trials, and not surprisingly, these agents still work. Our program also seeks to address this. The REACT program is about standard patient care and establishing the option that presents the least physical toxicity and financial costs without sacrificing effectiveness. Let's face it, it doesn't always appear very sexy when trying to obtain funding, but this type of research is essential and impactful for our healthcare system. Besides the fact that the REACT program addresses unmet needs in patient care, optimization, its structure and methods are part of its success. So how is REACT different from traditional trials? And what type of evidence is generated? This is our REACT program process diagram. Now let's look at some key elements of the process and the evidence generated. The first step is that we survey patients and healthcare providers. This is to evaluate variability in regular practice that will inform the selection of clinically relevant questions. Furthermore, surveying knowledge users, including patients and healthcare providers, help us to determine the most clinically relevant trial endpoint related to a given question. Finally, we publish the result of this survey to inform stakeholders on the state of practice. Surveying knowledge users ensure that our trials are relevant to everyday practice and possibly practice changing. Since 2014, we performed and published 17 patient surveys and 17 healthcare provider surveys. All of the teams address important issue encounter to the breast cancer journey, like hot flashes management, urogenital toxicity, optimization of adjuvant therapies in older patients with breast cancer, the use of bone-modifying agents, or granulocyte colony-stimulating factors. Once we identify clinical equipoise on a certain subject with surveys to patients and healthcare providers, we also perform systematic reviews to confirm clinical trial equipoise and to inform clinical trial design. Brian Otten is our senior scientist in clinical epidemiology. He helps us with all our systematic reviews. Since 2014, we performed and published 22 systematic reviews. These 22 systematic reviews have been performed evaluating standard of care interventions for the management of breast cancer, all tumor sites, breast cancer and prostate cancer only. The majority of the reviews were related to supportive care and survivorship interventions. All of the systematic reviews follow the PRISMA guidelines. The median number of authors and trainees involved in each publication were 12 and 5, respectively. In over half of all reviews, the first author was a trainee. Most of the systematic reviews confirm clinical uncertainty, and 3 systematic reviews provide firm conclusions. The majority of the systematic reviews provided specific recommendations for future study, and the result of the systematic reviews were incorporated into peer-reviewed grant application and the design of clinical trials. Based on the result of our surveys and systematic reviews, we design our trials with experts from different research disciplines in methodology, biostatistics, health economics, and patient-reported outcomes. Our 3 key experts are Brian Otten, Greg Pond, and Kenapa Tavern. As mentioned previously, our trials have a very pragmatic design, so it can be done on time and on budget. The concept of pragmatic trials is not new, and pragmatic trials aim to test effectiveness of an intervention on broad routine clinical practice. This means that eligibility criteria are broad, often only 5 to 8 criteria to ensure applicability of the results to our population and also rapid accrual. Our clinical trial coordinators are actively involved and thoroughly review the protocol to ensure feasibility. The protocol usually becomes shorter and clearer at each iteration. And the big piece of our method is the integrated consent model. With this model, the physician explains the study and its rationale to the patient, what the patient is asked to do if they decide to participate, and then the physician obtains verbal consent. Patients are provided with an information sheet to support the discussion and as a reference. The other key highlights of our practical methods are the randomization is done in clinic by the physician. Usually our trials don't require additional clinic visits, only a standard follow-up visit. The consent and follow-up can be done virtually, and we use electronic medical records for real-time data collection. All of these characteristics render our process efficient and contribute to high accrual rate. Using this method, since 2014, we completed 20 clinical trials and 7 are ongoing. Let's look at a few specific examples. Regarding chemotherapy-related procedures or supportive medication, we show that breast cancer patients don't need upfront central line when administering adjuvant or neoadjuvant chemotherapy. We also show that 5 days of filgrastim injection is as good as 10 days as primary prophylaxis for neutropenia induced by chemotherapy in breast cancer patients. The cardiac surveillance with echocardiogram for patients on adjuvant NCR2 targeted therapy can be done every 4 months instead of 3 months without safety issue. Finally, in the palliative care setting, giving bone agents every month is not superior to every 3 months for patients with bone metastasis from breast or prostate cancer. All of these trials show improved patient experience and reduced costs for both the patients and healthcare system. Since 2014, we performed 4 economic analyses. Here are examples of 2 of them. REACT-G showed that 5 days of filgrastim was not inferior to 7 to 10 days in terms of risk of infection and reduced risk of hospitalization. Furthermore, it resulted in cost saving of more than 3,000 Canadian dollars per patient. REACT-BTA demonstrated that de-escalation from 4-weekly to 12-weekly administration of bisphosphonate or denosumab reduces cost by more than $3,000 per patient and improved quality, suggesting that 12-week bone-targeted agent is superior to 4-week bone-targeted agent in breast and castrate-resistant prostate cancer patients with bone metastasis. You can see on this bar graph that our program continued to accrue steadily since its start in 2014. We use a pragmatic and robust model that allowed us to do well even during the pandemic, as you can see. We are estimating that by June 2024, we will have 5,000 patients enrolled. The program has also expanded provincially and nationally since its creation. We opened trials in 20 different sites across Canada. As you can see on the map, most of our sites are located in Ontario, but we also have sites in Alberta, Saskatchewan, and Nova Scotia. We have a coast-to-coast presence. The recent innovations in our REACT program include centralized management of clinical trials to support research in centers with less research infrastructure. For this study, staff in Ottawa performed data collection and follow-up with patients in other centers. The program is also exploring the use of artificial intelligence and machine learning to fundamentally disrupt the way trials are performed. Let's face it, traditional learning techniques are limited, so it's time to integrate artificial intelligence and machine learning to enable learning of complex relationships among variables by analyzing large amounts of data. A trained algorithm can then make treatment predictions based on individual patient characteristics. All trials show improved patient experience and reduced costs for both the patients and the healthcare system, but despite this, funding of these trials are still an issue. We are running trials at very low cost average, leveraging our practical method. We have a very low per case funding compared to pharma trials, so many trial managers reject our trials. The funding came mainly from local grants, such as to AMO, also from individual donation and 3CTN. We have partnered with Thunder Bay for NOAMA twice now. And as I mentioned before, to include sites that do not have local trial support staff, we are performing a study with centralized management. Most importantly, we hope to have a bigger voice with provincial and national decision makers and stakeholders. For this, we are trying to build a relationship with Ontario Health. The REACT program is helping Ontario Health by optimizing patient care. Again, substantial saving could be achieved by optimizing the use of current registered treatments and interventions. And also, we are fostering important collaboration between multiple sites and are developing a model that can be used by sites with little resources. To sustain our program growth, we need support from Ontario Health. We need Ontario Health to champion our program with provincial and national decision makers, and we need funding for simple pragmatic trials that will improve patient care. The conclusions are the following. The REACT program uniquely engages patient and healthcare providers in the identification of practice variations and also in the appropriate trial design to answer patient-centered questions and to allow the optimization of patient care. The program also seeks to make the performance of clinical trials less cost prohibitive. This strategy has allowed greater trial access, improvement in the availability of evidence-based care with substantial cost savings to both patient and healthcare system. The take-home message is the REACT program constitutes a major opportunity to leverage knowledge from everyday clinical practice to improve clinical care, decrease healthcare costs, reduce disparities, and ensure healthcare system sustainability. Thank you.